Good evening, friends, and welcome back to the Thursday evening teaching sessions being conducted at LTMMC Sion Hospital, Mumbai, and brought to you courtesy Alchem Alpha Division. Thank you all our online friends for joining in. As usual, the format will be, we will have one case discussion, which will be followed by a short topic discussion. Today's topic is being conducted by Dr. Anjali Gokarn from Vasai. First, we will have a case discussion, which is presented by Dr. Srihari. We once again thank the authorities at Sion Hospital for allowing us to conduct these clinics. Thank you. Dr. Srihari.
Good evening, everyone. 3-year-old male child, first by birth order, born out of non-consanguineous marriage, residents of Sion, hailing from Gujarat, Muslim by religion, Kotaria by community, with mother as informant, reliable, came with the complaints of weakness of limbs since 1 month. History of presenting illness. Patient was apparently normal 1 month ago and then developed fever, high grade, intermittent relieved with medication associated with cough, no expectoration, no post-acid vomiting, and was taken to the local private clinic. And symptomatic treatment given, and symptoms started improving. But patient developed weakness of lower limbs in the form of frequent falls while walking from the next day and associated with bilateral lower limb pains. Then the weakness progressed such that the child could not move the limbs, then could not roll over the bed and could not sit up from the sleeping position. Then child progressively could not lift the object, and progressively over 7 days, child could not hold the objects independently. No difficulty in breathing and swallowing was noticed, and child could indicate the bowel and bladder habits. Child then taken to the local private hospital, and some nerve investigation was done and told to be abnormal and referred to our hospital for further management. Then child got admitted, and for after examination and evaluation, child given some IV medication, following which child showed apparent improvement of weakness and discharged, and physiotherapy was advised for the child. At the time of discharge, child could roll to side, child could roll over and could sit up from the sleep and could hold the objects and raise the arm above the head, and child could stand with support. Then child was routinely doing physiotherapy, and then after 2 weeks, child again developed pain in bilateral lower limbs and worsening of weakness in the form of the child could not do routine physiotherapy and then could not roll over, and the situation was that the child could not sit from the sleeping position, and uh, then to involve the upper limbs in the form of difficulty holding the objects and raise limbs above the head independently. Then again, the child got admitted in the hospital, and child complains of frequent coughing while having food. No history of loss of consciousness, seizures, behavioral changes, or emotional disturbances. No history of visual disturbances, double vision, squint, drooping of the eyelid. No history of difficulty eating, dribbling of saliva. No history of deviation of angle of mouth. No history of inability to close the eyes. No history of hearing disturbance or giddiness. No history of regurgitation of the food or change in voice. No history of altered sensations or loss of sensations. No history of swaying while standing. No history of bowel bladder disturbances, palpitation, sweating. No history of headache, vomiting, neck pain, ear discharge. No history of fall on back pain. No history of rashes, joint pain. No history of TB contact or weight loss. On due course in the hospital, child weakness progressed and shifted to the pediatric ICU, and then on account of frequent cough and breathing difficulties, child got electively intubated and treatment continued. Past history, no history of similar complaints in the past, no history of previous hospital admissions, no history of any chronic disease in the child. Antenatal history was there is no significant antenatal history. And natally, the child was birth and developmentally child was normal. No history of neonatal jaundice, sepsis, or congenital anomalies. And developmentally, also child attained all the milestones appropriate for age, and child had received all the child was up to date with immunization, and no history of recent immunization was found. Child was exclusively breastfed for up to 6 months, and now the child was taking food well from the family pot. The child was a mixed food intake. Child has mixed food intake. Family history, there is no any history of any similar complaints in the family or any congenital disease in the family. And child belongs to the lower middle socioeconomic class according to the modified Kupuswamy classification. In summary, 3-year male child.
Shows the next first slide. So he developed fever, and the next day he developed the weakness. What was the interval at the beginning?
The child developed fever on the first day, and the very next day, on medication, the child fever was improving. There was no fever. There was only fever for one day. And the next day, the mother noticed the weakness, like in frequent falls and pain. The child was telling pain in the limbs and frequent falls, but the fever was only there only for one day. But he had cough and expectoration of cough and some symptoms which he took medication. But the interval was only one day. Soon after the next day, the child developed symptoms.
And from the pain to the not getting up was also overnight.
No, not overnight.
Then
the first day the child could not. The child was complaining of frequent falls, and in 2 to 3 days the child could not. The child could not roll over the limbs. Then on over the period of 7 days, it was full fledged. Like child could not roll over, child could not sit up.
no, so you've written weakness progress, child could not move lower limbs. So I'm asking that from the pain in the lower limbs to the point where child could not move lower limbs, what was the gap?
It was initially every symptoms progressed over 7 days. Finally the mother took the child to the hospital after 7 days. It was 7 days period. Child was completely bedridden from the day of the symptom onset. Till that the child was able to do some activities but diminished.
Okay. Okay. So the question, sorry. So the question means what we have to discuss here is that there was 1 day of high fever, which is like it could be anything. Next day the fever settled, and next day the child had frequent falls. Okay, weakness is his assumption. We don't know. The parent would have come to you next day with frequent falls. So yesterday fever, today frequent falls. What would you think at that time? And how will you approach that child at that time?
Viral myositis. Viral myositis.
Okay, viral myositis. Okay, good thought. Now dissect it further, and what is the classical story in viral myositis, and how will it be little different from this?
Pain would be most prominent feature, and presence also not immediately after the fever onset. Takes a little longer to develop.
So classically, we see fever for 2, 3, 4 days. Then towards the end of the illness, we see a lot of pain, and they say now he can't walk and all, but not frequent falls. Can you get a lot of pain on second day, first day of the fever? You get in dengue, chikungunya, yeah. So would they fall frequently?
They refuse to get up or refuse to move.
Right. So they're reluctant to walk because of the pain. That may be a complaint. But if they walk, do they fall frequently?
They don't fall.
No, they don't fall frequently. Okay. So one is viral myositis, but these are the differences. So we've understood that. What else?
Could be ataxia, cerebellar involvement, cereballitis.
How will you fish it out from the history, whether it's ataxia?
We'll ask about the gait of the child, if he's trembling or if he's falling to one side, and other symptoms related to the cerebellar symptoms could be asked for, like tremors or titubation, any movement of the eyeball, if anything unnatural is noticed by the parent.
Okay. So which brings us to the question that whenever somebody comes to you with frequent falls, what details do you want to ask about the frequent falls, which will give you idea about where the problem is?
So we would like to know whether after the fall the child was awake, was the impaired awareness or not. Because if there was loss of consciousness, even then the child would fall. So we would like to rule out that as a.
Okay.
Peripheral neuropathy sign ask for if the child has poor sensation while walking. He could have slipping of slippers as well.
Okay. Will that be acute? Like
No,
within how it's described in a few hours?
no, less likely.
Okay.
So
So I
in
think-
coordination,
yeah.
In coordination, I mean, when the child was not walking, he would be sitting and playing. So we can watch for incoordination. And if sudden onset falls, you will also ask for any ingestions or since this is an acute history, intoxications and ingestions.
Yeah.
What prevents you from falling while walking? One is your vision. Is this child suddenly gone blind? And he's just falling. Okay. Frequent falling is not pain. Frequent falling is neurological. The question is, does he have a vision? Okay. His vision could be slowly going down. He has not realized. And now he cannot see, he starts falling down. Okay. So you need a vision to be sure about that. What next you want? You said rightly.
Sir,
that
hold the mic
equilibrium.
close.
Okay. So cerebellum. Okay. What else? You must have enough power. And you must have a normal tone. Correct? In coordination comes as a part of cerebellum. So now you need to have a motor system, tone and power. You need to have a cerebellum in coordination, and you need to have a vision. Okay. Anything else you need to know?
Complaints of dizziness or vertigo.
Very good.
like
So it could be vertigo, it could be the ear, right? Good. So that could be not necessarily neurological, but it could be also part of neurological. Okay. Anything else?
syncope or something.
Now suppose I have a vision, I have a power, I have a tone. Okay. But I don't judge properly. Okay. Why should I not judge properly? Frontal lobe leaves.
Okay.
Okay. They may come with bilateral leg problem. I'm just trying to first push the anatomy. Now it's not higher up, so you leave that part. And now you start looking at more and more in the history to say, where is the anatomy of this? Neurological, surely. So now how will you rule out one? You said that cerebellum, yes. So that's possibly not ruled out. What about power and tone? What question would you ask to say that power and tone is not a problem in this child?
So means what we are trying to say, see, learn to take a history at a very basic level for every symptom. So I mean, none of you, I would be happy at least one of you said frequent falls means how frequent, how many times he fell. Then the question is he walking normally and then falling, or he is walking abnormally and then falling? What is the difference in the two?
Walking abnormally is a gait disturbance. Cerebellum is.
So what we mean is that there is something wrong with tone, power, coordination. If he is walking abnormal all along, 10 or 20 steps and then falling. Whereas 20 steps are bang normal and then he is falling. So there is nothing wrong with tone, nothing wrong with power, nothing wrong with coordination. So something suddenly is happening after 20 steps. No? So all these details we have to ask so you have to learn. This is how you try and sift them out, right? So now in this child, what do you think? He's also got pain in both lower limbs. So how do you correlate that pain to these frequent falls?
Pain is not the cause of frequent fall. I can fall once because I have pain. Okay.
No, say is the pain the cause of frequent falls? Why not?
Because child wouldn't attempt walking after the first.
I don't stand. If he has been at the most, he may make effort once, realizing that he can no longer walk. There's no question of falling all the time. Second, repeated falls, no. One fall maybe, first fall.
That Rajesh was talking about is, suppose this child was already toe walking because of some earlier unknown issues. Now he started tipping more and more. Okay, but in that case, what he said was the gait earlier, whether he was walking well, running well, climbing up. He said he was doing all that, and therefore we know that here is a normal child. Okay, who suddenly develops that after a small episode of self-limiting fever. Okay, where is the anatomy now out of all this?
So we said neurological we have come to. Now upper motor neuron or lower motor neuron?
You're so sure it's not upper motor neuron? Give it try.
In upper motor neuron, there would be spasticity and no any central. He is not unconscious or other signs of cerebral involvement.
The upper motor neuron not come from the spinal cord? So now convince first me upper or lower motor neuron. You're right, mostly lower motor neuron. Okay, could it be upper motor neuron also? And sometimes it could be even up there, but not frequent falls like this. For example, if you have a slowly enlarging hydrocephalus, then the pyramidal fibers which are close to the ventricle are first going down to your legs, and you may start finding gradual progression of difficulty. But this is sudden, so we are not talking about that. So even central cause can be without a neurological symptoms related to central cause, right? So who will rule out such spinal or higher up causes of an upper motor neuron lesion bilateral lower limbs?
Suppose somebody gets a sudden hemiplegia, sudden infarct and hemiplegia. Will they fall frequently?
The person could be in spinal shock that could cause the weakness.
Even without the spinal shock, there would be weakness. Suppose I get a hemiplegia, suddenly there will be weakness. That's hemiplegia. Two questions. One is, will the person fall frequently?
He won't be able to once, and then he won't be able to get up.
Correct. So that is the difference. So in short, upper motor, as in cerebral problems, have to be usually unilateral. And if they are bilateral, then what? What has to be accompanied? Sudden onset bilateral upper motor cortex problems, motor cortex or whatever. Bilateral means sensorium has to be affected, no? How can you have no sensorium affected and bilateral problems? Right?
So I talked about the gradually progressive hydrocephalus because that's not so rare. And if you have a slowly come, but that is not acute. That's gradually progressive and difficulty in walking before falling. This child suddenly starts falling. So he had no difficulty till then. So we are out of that. Now rule out
Spinal cord. What are the parts of spinal cord which can give this?
Involvement.
Okay, so what?
Everyone speak in the mic so that you can hear. Everyone online also can.
Level is only on examination. No? So what spinal cord possibly the person can walk and falls. That means he can walk and then falls. Can there be sudden spasms of the muscles? I'm walking, I suddenly fall and my sensorium is not lost. I'm aware. Can I get sudden spasm and fall? Very
I'll give you
rare.
a clue. Okay. That I was not doing well for some long time. I had fever off and on. And now suddenly I developed this. Okay. Could it be tuberculosis? And how does tuberculosis lead to that of an acute onset? So I'm asking you, does a TB spine comes as a differential diagnosis in this child? Probably not, he was healthy, etc. But that's one upper motor neuron lesion. Can TB spine cause sudden paraplegia? Or it's a gradual worsening?
It's a gradual worsening because of the compression.
It also cause sudden. Gradual is a space occupying lesion compressing. Okay. Can it happen suddenly? I'll ask you one simple question related to that. When you say tuberculous meningitis, okay, it has a hemiparesis often. Where is the lesion? Vascular. So,
Is
a
there
spinal
something like spinal
vasculitis.
vascular hemiparesis?
And the spinal vessels go circumferentially. So you have so in TB spine acute paraplegia is known. Could this be that? And now he will tell us later on fever off and on, all that. We are on the second, third day of the story. So could it be one of those?
No, first, you're answering this question or you're saying atone. Okay, is this atone? The frequent falls can be atonic seizures. So yeah, theoretically, yes, but then we have to ask details of the history as to, like we said, suddenly out of nowhere, the child collapses and gets up. Though atonic seizures are very uncommon, they are very rare. Okay. And there'll be something after the fall. He will not get up quickly.
And maybe even before fall, because atonic seizure in a normal child less. Can it be hypertonic, not seizure, but fall? Very rare.
There is something called as a spinal meningitis, where the meninges higher up are not involved. But the point is, it will be one-time issue and not frequent falls. Okay, once I happen a hemiparesis, I don't have a frequent hemiparesis. So tuberculosis disease will have gradually onset like a space occupation lesion or spinal vasculitis, acute onset, but not frequent fall. Therefore, this is not. Could it be transverse myelitis? Again, paraplegia. Again, not frequent falls. You are paralyzed. You cannot get up. So this is there for lower motor neuron, right? You go systematically and come to lower motor.
Parts. So can it be anterior horn cell? Can it be nerve root? Can it be NM junction? Can it be muscle?
So this may be an NM junction problem where the patient is regaining strength to walk again and then falling frequently.
So when you discuss NM junction problems and when you discuss about regaining strength, put it in a correct perspective. What does it happen like 3 o'clock lost strength and 3-1 regain strength? How does it happen? Put it
Over
correctly.
the day.
Progresses over the day.
So fatigable after repeated use of the muscle, and then rest gives some energy back. Seen most often in which muscles?
Proximal.
Eyelid.
Eye muscles. Why?
It is used most.
Used most. So therefore the first symptom will be ptosis, right? Okay, so that. So it's not acute. Now suppose it is acute NM junction. Then as a thought process, what could it be? Acute NM junction involvement.
Botulinum.
So toxin. Okay. So that will not recover immediately. That will be paralyzed then. Right? So fine. So further. So can it be anterior horn cell? Let's discuss that. Then let's discuss muscle. What do you think? Anterior horn cell. Any thoughts?
So anterior horn cell would be asymmetric, and this seems more symmetrical.
You don't know that.
On history, it's very difficult to exactly make that out. Anything else?
And a very symmetrical weakness, that fellow is less likely to get up. A unilateral or partial or patchy weakness fellow will try to get up.
So I think here we stay with anterior horn cell. Polio-like viral infection. We don't know whether it's symmetrical or asymmetrical. Yes, but both the legs are involved. Maybe asymmetrical and he's just falling down. Okay. And a day of fever and following that. Okay. So, and would anterior horn cell disease have pain? Also has pain. Because some anterior horn cells are not yet paralyzed but irritated. Therefore, earlier typical polio used to have a neck stiffness, back stiffness, and
Tripod
many
sign.
other. Yes, tripod sign. So anterior horn cells irritant, you get a muscle spasm, paralyzed, you get a weakness. So to begin with, you can have that kind of a thing. So possibly we keep that in mind, and let's see how we further go. What about nerves?
Can it be peripheral nerve involvement?
The course of illness would be longer in a peripheral nerve involvement.
So most peripheral nerve stories are little long stories, not like a sudden thing, and not generalized. So generalized can only be toxic or poison or something like that, right? And what about muscle?
What is the typical symptom of a nerve involvement?
Radicular pain, pins, and since
Weakness is common to many. Pain is also common to many.
Tingling numb. Yeah, so tingling or paresthesia. Okay. And muscle?
Again, the generalized involvement is uncommon if it's a muscular.
So generalized is possible, but such acute is not possible, right? And it is usually seen, as we said, as viral polymyositis, where there is more pain than weakness. So those viral myositis who refuse to walk, is their power affected? Not this. We started our discussion with viral myositis who refuse to walk. Is their power affected? No, their power is normal. So in fact, if you see them, you have to demonstrate that power and reflexes are normal, and it is just the pain, and that is what reassures the parents that this is not polio or this is not anything.
How do you know that it is not weakness? You said viral myositis has no weakness, pain is the factor. How will you know in the history? So in a painful condition, how will you rule out a weakness on the history? She will ask them whether when he's lying down, can he move his legs? Okay. So small little things will rule out. I think we have always said that history is thought in action. You think and act. Okay. So we come to that. But which part of this whole lower motor neuron, the pain is a very significant factor. And what kind of pain? When you move the legs in a particular fashion, you get pain. Okay. Not pain just without moving. What kind of that anatomy is?
Nerve root.
The roots are painful. So,
okay. So this sentence you must always remember. This is Dr. Udani has told us. Anterior horn cell atrophies. Roots pain. Nerves tingle. Okay. This sentence should be in block letters in your mind always. Okay. So anterior horn cell atrophies, roots pain, nerves tingle.
Now we have considered different parts of nervous system, and we have analyzed that it could be peripheral nerve, muscle, some points in favor, some points against. Now for a moment, let's analyze what has happened and let's see how will you put the history. The child is able to walk and falls and walks and falls. That means what? If he is able to stand and walk, that means the power is not bad. But he still falls, that means the power is giving up somewhere. Some of the muscles are more weak than the other muscles. He has the strength and courage to stand, therefore no pain. Higher centers are out, there is no question. He makes an effort to walk, but sometimes it just gives way. Some of the muscles are weak. So this story is classical of a child who is developing weakness. Where the weakness is, we will just find out right from anterior horn cells. So it's an evolving weakness which has started now, and maybe the further story confirms that an evolving weakness has now developed into a complete weakness so that he's not able to walk. Maybe in lying down position, he may be able to move the legs. That means the power is maybe great too, but he's not able to support his body. So this is a story of a progressive weakness, most probably lower motor neuron. Now that we will analyze, as we just said, right from anterior horn cells.
So acute onset, fastly progressive, just 2-3 days. Okay. So acute onset, fastly progressive, preceded by a day or two of fever. That is our whole story of that. And the anatomy being roots primarily. And now we come to pathology. What kind of pathology?
Trauma?
When there is pain and fever, inflammatory. So acute inflammatory onset with fast progression. That much we knew. Okay. Now comes the etiology.
Infective inflammatory? Some pyogenic infections, something.
What etiology?
Or hypersensitive inflammatory.
Pyogenic, the fever got better without using any antibiotics.
So acute pyogenic infective pathology, unlikely. Inflammatory pathology, yes.
Inflammation is infective, non-infective. Non-infective inflammation is traumatic or immune-mediated. Now tell me, is it first infective or non-infective? And if it's non-infective, traumatic or immune-mediated? Trauma may have been missed also. Okay. He toppled because of something, got hurt there, and the whole neurology started. Okay. So now first tell me, can it be infective? To my mind, yes, because it started with fever. So who will contradict this statement? It is not infective.
Come on. What is the progress of the fever?
Okay. So it's not infective. Okay. So it's non-infective. Could it be traumatic?
Why not? Even if, sir, as sir said, he has missed the trauma.
It won't be progressive.
The hematoma is increasing in size.
So would there be some local symptoms or no? There has to be, if hematoma is increasing, local swelling,
So
etc.
story starts with local pain, thereafter something. And what kind of hematoma? Subdural hematoma grows slowly. Okay. If it's anywhere else, extradural can be very disastrous. So also the subarachnoid. And what's the reason? It's not common there, but up there it's not uncommon. So why does subdural hematoma go slowly up? Comes as a space occupying lesion, but the subarachnoid and extradural can be fatal or damaging. Subdural hematoma is a venous bleed. Okay, extradural and subarachnoid, yes, are arterial bleeds. When artery bleeds, it will go on bleeding and it will cause shock, it will cause damage. But a venous bleed is slow and that will take few days, few weeks. That's how trauma is out. So immune mediated. Okay, could it be some poison, toxin? Okay. Could it be vitamin deficiencies? Some vitamin deficiencies cause nerve lesions. Okay. What about those?
Vitamin deficiencies won't be acute.
So, but fever is the onset here. So when fever is the onset, you want to correlate with that. And finally, you call it an immune mediated. Okay. Now the problem doesn't end there. This fellow is discharged and comes back. Now what is this?
He was given treatment, he improved, and there is a recurrence.
So something like a relapse because he improved after medication and then again, I mean, the effect was there for some time and it again came
So
up.
what recurs?
So is TB fever off and on relapse? Okay, I had fever for 2-3 days. My doctor said, go home. After 2 days, I came again. Would he call it relapse? So then, for a relapse, there has to be a recovery and then relapse, isn't it? Apparently improved. Okay. So we don't know. He apparently improved means his power might have improved by 1 degree or whatever. And okay, so it may be a continuous disease itself. Okay. If I get urticaria, I suddenly get the lesion and they disappear. And then they come again. Do you think it's a relapse or it's a problem same? I get an asthmatic attack, then I get better and I come back again. Is it relapse? Possibly the same disease with aggravation. Okay. So we will have to really not know what improvement occurred and what was the difference between discharge and
So when he was discharged, what was the condition of the child?
Roll over. And he after discharge for 2 weeks he could do the routine physiotherapy also. But after 2 weeks, once again the mother noticed the child could not do some of the physiotherapies and started complaining of pain again, and then progressed.
Okay.
So I think this proves that he improved, because there is a reliability or there is a correlation between starting of treatment and beginning of him. It's not just by accident that he has improved. And like one would expect, if he had improved overnight, then one would worry.
Yeah.
But he has improved slowly, like one would in an illness, and he has improved considerably. So the improvement is treatment related, and then there is a recurrence.
The only question is, the first time we have discussed only legs involvement. But on discharge, he said hand can go up.
No, even he said that it
Earlier
progressed. Yeah, first time it progressed to
So
hand
the question
also.
is, he had started improving, but then he came back with vengeance. To me, he has not been cured. Okay. It's like I start an antibiotic, he gets better. Sir, fever is less, now go home, stop the drugs, and the fever comes back again. I don't call it relapse really, but it's really the same disease which is not fully treated. Okay. That is my impression, rather than, yes, all immunological disorders could come again, relapse.
Either
Yes.
not fully treated
Yeah.
or a disease has recurrence as its salient feature. A cured disease also can recur,
Yeah.
like
But
an immunology.
typical recurrence is you started walking, running,
Complete
everything,
normal, and
and
then-
now you come back after 2-3 months again. Yes, that is a typical recurrence. Whereas here, possibly it's a partial treatment.
Yeah.
Okay. And sometimes whatever treatment was given could have partially been improving and was not enough. If discharge was not discharged, possibly he would have started worsening there only. So it could be one of those. It's like a partially treated bacterial infection. Gets better, but does not get cured, right?
partial improvement. Maybe
Partial
with adequate treatment also one can improve only partially with the relapse.
He was given IV drug, no? Must be antibiotic. Okay, what IV? Common IV drug is antibiotic only, no? What else? And he improved. So
Nowadays, paracetamol is also frequently given IV.
Could it be multiple sclerosis where it is disseminated in time and space, relapse kind of a nature, but although it's not lower motor neuron,
So that's what sir is saying, that for you to actually call it a relapse, you should have a reasonably complete improvement the previous time. And then you think of neurological conditions which keep relapsing, like multiple sclerosis.
for
So here,
example, I'll give you a simple example. You have a pneumonia who comes with hypoxia. You start antibiotics, you start giving oxygen, his dyspnea disappears, his stats come up. Now you say, okay, you are all right, you go home. And if he's not fully treated, he may come back again.
With an empyema.
It's only a semantic difference. What I mean is that a typical relapse is when you are completely all right and you come back again. Okay. Look at what is a relapsing nephrotic syndrome. You say 2 relapse, 3 relapse in a year, whatever. That means the definition includes complete cure and recurrent again. That is typical relapse. Anyway, that's not very important. So here now, what is the final impression on the history?
Tell us your diagnosis on history.
A 3-year male child, born of non-consanguineous marriage, birth and developmentally normal, imminent till death, and belonging to the lower middle social-economic class, came with the complaints of weakness of limbs since 1 month, with apparent improvement with the treatment and recurrence of the symptoms, complaining recurrence of the similar complaints, probably a case of relapse of the GBS, or it could be CIDP, or it could be chronic inflammatory demyelinating polyneuropathy.
So yeah, that is okay. I am just suggesting that now as a collective, all of you improve this summary. So how will you, what words will you put in this summary? What adjectives will you put which justifies your diagnosis? So came with, instead of complaint of weakness of limbs, you start saying acute onset, rapidly progressive, weakness of both lower limbs, preceded by what has made you localize it to the nerve roots? Pain. So preceded by pain. And what else? Ascending paralysis. Okay. Then, okay. With a fever prior to the onset of these complaints. Okay. So that all these things tell you that this is a nerve root related weakness. With, don't see this word apparent now, we use it very loosely. So instead of apparent, with say with partial improvement, right? Apparent means what? What is the meaning of the word apparent?
Not sure.
Not sure. So why do we want to all the time say not sure, not sure? Okay. So we should say with partial improvement. You are sure na, that he could lift his hands, he could do physiotherapy, etc. Right? So with partial improvement and reoccurrence of the similar symptoms.
So I think summary should have many adjectives and anatomy, pathology, etiology, and functional impairment. That's fine. So that's why we said acute onset, rapidly progressive. We are using adjectives of the root lesion. Okay, we are giving the anatomy. Probably or infection-induced inflammatory disorder. I'm giving the pathology and etiology and partially improving with some treatment, but coming back again with worsening. This is my 2-line summary of this. Now, some of these things are right, but not important. For example, which socioeconomic group does not matter here. Consanguinity may be to a small extent. Acute onset is unlikely to be related. So the point is, we have said this before, your presentation should be A, B, C. What is A? Accurate, B, brief, and C, clear. As brief as possible. Because examiners are old enough not to pick up what youngsters could suddenly say. Okay, and it takes time. If you make it very brisk, small, quick, then I understand, right?
It's most difficult to summarize in short.
Yeah.
It's very easy to go on talking for maybe 2 paragraphs without really making much sense. But summarizing, the shorter the summary, more difficult. Your thoughts have been crystal clear.
And you have less time in the exam. Okay, so sometimes you might say, no, doctor, stop it. Now tell us what's your final diagnosis. Now you suddenly get that. Lastly, I think every time we have seen a big list of no list is more than yes list. Okay, symptoms are only 3, but the no list, another 10, 15. I think we have said this again and again, relevant, which parents may have forgotten to mention. Don't say no history of unconsciousness, no history of seizures. They would not forget to say that. No, why have you to ask them, Did you were unconscious? No. They would have come forth for that. So take a note of that, right?
And then see again, it's to save your own time because you want to reach investigations and management. So you can club and say no history suggestive of cranial nerve involvement. Club. Now you are also inviting a question. Nasty examiner say, what history will tell you cranial nerve? But then you are ready with your answers, drooling and this and that. So then you can't be caught wrong on that. Okay, so this way you have to answer.
So just because he said is, I'm the examiner now, tell me which cranial nerve involvement you can't pick up by the history. You said no history of cranial nerve involvement. Which cranial nerves you may not get the history. I'm just trying to put across. I ask you such funny question. He has already marked you as passed. And he wants to see whether you can be a medal candidate. So I put up this question.
To make an effort, you can start this case. This is a case of weakness. The weakness is probably because of the peripheral nerve involvement. This weakness is improving and worse. This weakness is probably bilateral, progressive, starting with lower limbs and going up to upper limbs. So you are adding, is it not a case of weakness? Weakness, waxing and waning, lower motor neuron, upper motor neuron, and probably then you come to a nerve root. I'm sorry, a nerve root as a diagnosis. So this is your summary.
Okay, go on. Examination.
General physical examination. Child is conscious, cooperative, and alert. And on examination, the child was vitally stable. Then no pallor, no icterus, no cyanosis clumping edema, and head-to-toe examination was within normal limits. Anthropometrically, child had underweight and moderate pasting. Then on CNS examination, child is conscious, active, lying on the bed with lower limbs external rotated and upper limbs by the side of the body. And no cranial limbs were all cranial limbs were within normal limits. Then water system, there was no atrophy or any decrease in the girth of the muscles. Nutritionally, the child was good. The tone in both upper limb and lower limb, the tone was reduced. The power, there was 2/5 in the both sides of the for shoulder and for upper limbs, and for wrist it was 1/5, and for lower limbs it was for knee it was 1/5 on the bilaterally, and for hip also it was 1/5 all the vessel, all the actions. Then for ankle it was 1/5. Then for trunk it was 1/5, and for neck flexion and extension both 2/5. So the reflexes, the superficial reflexes, corneal reflex was present. Rest of the reflexes were absent. Deep tendon reflexes were 1+, and the sensory system involvement was normal. It was the child could feel the touch, temperature, pain, and there was no symptom. There was no signs of any cerebellar involvement. There was no nystagmus, tremors, and no sense of meningeal irritations. And straight leg raising test was positive. On summary, the 3-year male child born of non-consanguineous marriage came with the complaints of weakness of the limbs with the partial improvement on treatment with hypotonic lower motor neuron type ascending, bilateral symmetrical, distal and proximal both equally involved with normal other CNS examination finding, normal other systemic examination finding is a probably case of relapse of GBS and or chronic inflammatory demyelinating polyneuropathy.
So you mentioned neck flexion extension power 2/5. So how do you look for that?
You have to make the child turn laterally and ask him to could he flex his neck and neck down and back with gravity eliminated.
Okay. So good. So the point is that whenever you mention 2/5, you are saying gravity eliminated. And in many movements in your normal supine position of examination, gravity is not eliminated. So you have to change the position. So remember at which joint gravity is eliminated in the lateral position, and remember that, because in the exam you will be caught on that. Okay, you are saying 2/5, how did you check? So you have to say that I put the child in lateral and then checked, right? Okay. Now, can we just summarize your signs? So signs are significant weakness with hypotonia and reflexes just coming through.
Reflex was almost between 0 and 1.
Okay. So based on the signs, how do you decide? Forget the history. Based on the signs, how do you decide whether it's anterior horn cell or muscle or nerve or whatever?
Symmetrical weakness.
Symmetrical. Bilateral symmetrical, both proximal and distal almost equally involved.
So amongst the components of lower motor neuron, tell me which component reflexes should be 0. No reflexes. DTR should be absent. Which two components of the lower motor neuron? Huh?
Anterior horn cell and nerve root. Yeah. No. No.
Peripheral. So anterior horn cell has to have no reflexes, and peripheral nerve may have no reflexes, because if it's a complete lesion of the peripheral nerve, then there'll be no afferent, no efferent, nothing. But the problem is here it is bilateral and symmetrical. So we already discussed that nerve is not an issue. What I'm trying to say is we discussed on history that where you localize, even after findings, you must be able to justify why these findings suggest a nerve root. So sir said on history that polio-like viral illness is still possible on history. So now I will ask you on examination. After examination, do you think it is some enterovirus? So what will be your arguments?
But polio-like illness could be also symmetrical, no? Involving everything. Then what does the word symmetrical mean? I have a severe polio where all four limbs are paralyzed. Would I call it symmetrical? So what is symmetrical? Each muscle in that limb is equally involved. Whereas polio could be involving all limbs, but it's patchy. One involving more, another spared. That is asymmetrical and symmetrical, not just simply symmetrical.
They are probably not seen too many polios. The child is not moving the limb, but I find that the flexors are okay, but the extensors are not good. The gastrocnemius flexors is good, but the tibialis anterior related muscles are not good. Overall, you feel that he's not moving the limb, but in that limb, there is no symmetrical weakness all over. Also, the right side tibialis anterior is more affected, left side is spared. That is also patchy. While for peripheral nerves or roots, there will be no patchiness.
So means here if I don't know if you noticed, but this child is well immunized. So that should be your first argument, that he is well immunized. So it's unlikely to be polio itself. Now, polio, like other viruses, theoretically possible, but on examination, because you got some jerks, 1 plus 2 plus whatever, so that takes you away from anterior horn cell. So you say that my diagnosis of nerve root is higher or more likely, right? How will you investigate him?
Sir, for complete blood count to look for any infection.
Transverse myelitis.
But no bowel bladder involvement, no sensory involvement, and no band-like sensation, no exact sensory level.
Progressive, okay. Fine. How will you investigate?
CBC and CBC for look for the infection, and any platelet count to look for any viral infection or any ongoing internal bleeding or something, hematoma and something. Then for nerve conduction study to see whether the child is he's having any acute inflammatory demyelinating polyneuropathy. And then for to rule out the viral myositis, I would like to do CPK MB to see whether he has any raised creatine phosphokinase.
So, which is the investigation which is going to confirm your diagnosis of GBS?
On MRI with the gadolinium enhancement of the nerve roots.
So say that first. So always divide your answer into specific investigations and other supportive investigations. So if you start saying all these first, and if examiner is in a bad mood, then he'll take you on a ride for all this. Do you think this is hematoma? Do you think this is that? Then your main thing gets left out. Okay. So MRI is very sensitive, gadolinium enhanced to pick up nerve sheath enhancement, which will tell you that this is GBS, right? Then your nerve conduction studies. What about CSF? Will you do CSF?
No need of establishing the diagnosis by doing CSF, but on CSF there is gastric albinocytological dissociation. The cells will be less, normally less, and the proteins will be more in GBS picture.
So why no need to do that?
We can do GBS usually diagnosed clinically, and with other investigations we can easily do. We need not do some invasive investigation.
What other reasons? You're right. What other reasons why you need not do that CSF and show that? When do you get this change in terms of timetable? At least second week or beyond. So one is it is not helpful in your early diagnosis when the child comes. Second reason, is this specific to GBS? It's seen only in GBS and nowhere else? Cytoalbuminous dissociation? What? Where else is it seen? So it is seen in any inflammatory disorder. Okay. So it's not specific to GBS. So that is why, because it's invasive, because it's second week, because it's not specific, you're not going to bank on it to make a diagnosis. So upfront, you're not doing that. As an add-on, it's fine.
I think the MRI has already shown you inflammation. So MRI has given you anatomy, pathology. How will you confirm etiology?
So by testing for autoantibodies in the blood or CSF?
We said it's triggered by infection. Okay. Don't you want to investigate what infection it is? Is it Campylobacter doing it? Would you like to look at that? So how would you defend the etiological diagnosis? Okay. It's presumptive, right? Post-infective inflammatory disorder. But post-infective is a presumption. Anatomy pathology is clear. So any comments on that? And you would have said that the type of fever does not give me any clinical clue to a probable narrowing down the infection. And finally, the infection has settled. So I would be wasting money in trying to do an etiological diagnosis. The management remains the same. And therefore, I will not look at that. Well, there would be some infections which are more prone to cause this, but that doesn't mean others don't. So why run through all that biofire kind of a thing. No. So if an examiner wants you to say, no, I'll do biofire, you say, no, it's not cost effective. Infection has disappeared. I'm not going to kill infection by some antibiotic or anything. Why do I want it? Clinically, no clue, self-limiting infection, difficult to diagnose etiology, does not change the management.
Yeah. Post-diphtheritic polyneuritis.
Could it be post-diphtheritic?
Not impossible.
Toxin
Related.
Single day fever settling down by itself, probably no.
But the diphtheria is it's a 6-week complication. 2nd week complication is palatal palsy. And then and by the time you have forgotten that he ever had diphtheria.
But typically a wider interval between fever and a neurological complication or a myocarditis.
These days we don't see that much. But now that there is emerging trend of infections and reinfections, this you have to keep in mind and may require to be immunized again. Very rarely we have seen, sir. Occasionally, sir had shown one cutaneous diphtheria, child with polyneuritis, and there was some non-healing painful ulcer which grew, C. diphtheria now, who diagnosed as cutaneous diphtheria. This is just to keep at the back of your mind.
Treatment?
How will you treat this child?
IVIG 2 grams per kg for over 12 to 24 hours.
So do you treat all GBS with IVIG? Means as soon as he comes, you diagnose GBS, you give IVIG. How do you decide that you should give or you should not give?
We see the rapidness of the progression of the disease, and if the child is improving on himself, then it is not indicated.
We can't wait to see the progression. We have to prevent the progression. You're right, but tell me further on that. He has come to begin with. You don't know whether he's progressing. So you would say that the chances of progression are very high in the first 1 or 2 weeks, but the neurologists consider it could happen anytime. Therefore, they say, no, forget about it. Mostly not after a week or 10 days, but you never know. So it's preventable. So neurologists today say that, anyway, give IVIG. But this time, this child got IVIG, right?
Yes.
But he did not improve completely. He came back with vengeance. So now what do? He is IVIG resistant immunological disorder. Right?
Plasmapheresis can be.
So first is, can you give IVIG again?
Yes, we can give the second
Nonsense.
trial because
if I use an antibiotic and he failed, you say try once more.
But
How
he
can
had
you try
shown
once
some
more?
improvement after the first dose.
You're right. Your answer is antibiotic is different. Okay, here immunosuppression. He will still try to do that. Suppose the second dose does not work. Then what do you do? Now don't say the third dose.
Plasmapheresis.
Plasmapheresis.
Okay. And at times when IVIG doesn't work, not necessarily in GBS, but even a steroids are tried. Okay, so their way of mechanism is different and it's not a first drug of choice. But yes, when it doesn't work, yes, and plasmapheresis being difficult, older the child, much more difficult because you need so much of volume and therefore that. What's the prognosis of this child? Suppose you give the second dose, etc.
Regarding the role of steroid in an acute case who's come, you are given IVIG. Today I have given IVIG. Is there any role for steroids? It's worth remembering. Pain. Even if you are given the IVIG, the child is in significant pain, has not slept last night, is not sleeping for 2 nights. It takes time for that. Here, if you give 1 dose of steroid, the pain disappears dramatically. So there is some role, though not directly related to the improvement of child, is symptom, because pain is important. A child is spending the whole night crying is not something which you want to live like that.
How was this child treated? Prognosis.
What is the prognosis of this child? He has failed on the first dose. He has come again with vengeance. You have given another dose. He is improving. Would he improve completely? What's your guesswork? Okay. In an exam, you might have said mostly, but mostly not. And I will look at on follow-up because nobody can answer yes or no. What's your guesswork? How will you put it in an exam?
So what's the prognosis in a simple first attack of GBS?
With properly treated GBS, good prognosis, first attempt, first attack.
So
But
excellent
depending on the
prognosis.
time.
Majority of them will recover completely, right? That's this. So now this is relapsing. So what do you think? How much will it take away from that?
So you would say generally the prognosis is good. Okay. Though small percentage are left behind with some weakness, but not total failure, not complete recovery, but mostly he will recover completely. So that's your answer. Okay. But also say that I need to follow up closely. I will certainly expect some improvement, but the question is, few may be left behind with some weakness. That would be your answer on that, right?
How was he treated?
Sir, first time he was given IVIG 2 gram per kg, and now also the second dose has been given 2 gram per kg.
Okay. It's been how long since you have given the second dose?
Second dose has been given only yesterday actually.
Okay.
It is not completed. It started.
Okay. Sir, yesterday only it is given.
This was the report saying that he has nerve root, the MRI of the spine has been done now, and it shows enhancement of the nerves.
Okay. Fine.
In an exam, you will have to examine the respiratory muscles also. And I'm sure you know how to examine for diaphragm, how to examine from intercostals. Okay, that is number one. Can you get a history to suggest that he is developing a respiratory muscle weakness?
Speech.
Very good. So hypophonia, aphonia, okay. So you will know that tachypnea, mild tachypnea would be the first sign. Change in voice would be another. Now last question is, some of them go on a ventilation, like this child went on a ventilation. What's the risk of a ventilation-associated infections? You must have seen everybody in an ICU who is on a ventilation has a very high risk of ventilatory-associated nosocomial infection. What's your take on that?
Child will have a higher risk of acquiring
Higher
ventilator.
risk?
Yes, because
Why higher risk? Usual risk, lower risk, or higher risk? Suppose he is immunocompromised, multi-organ failure, you will say, oh, higher risk. If he doesn't have that, you say normal risk. Could he have a lower risk?
because of prolonged intubation as well. So
He is already receiving IVIG, so lower risk of.
The biggest risk factor of ventilation-associated infection is an abnormal pulmonology. And these patients do reasonably well on ventilation. Not that, therefore, we can forget the sepsis, no. Okay. But the same sepsis, whatever all sepsis we have in our ICUs, these patients don't seem to, because, and this proves a point that a local defense is as important. Okay. Because it does not allow you to get the bacteria in. Okay. Thereafter, the next issues. And local defense. I've almost never seen a ventilated GBS or so getting into infection in the same ICU where everybody else is getting infected. The point that she made is very valid, that Many of them may not need a long-term ventilation. Okay, they start improving. But the risk is much lower as compared to anybody else, because the lungs have to be normal to fight the infection. If the lungs, and the common reason for ventilation is the pulmonary problems, of course, or the neurological problem. This child has up there everything fine, and lungs are fine, heart is fine, so he will fight out much better, right?
How do you judge the weakness of respiratory muscles? The child is sleeping. Don't touch the child. Case number A, he has diaphragmatic weakness, not much of intercostal. Case number B, he has intercostal weakness, not much of diaphragm. Don't touch the child.
Come on, come on. On inspection.
How do you judge the severity of asthma? Suppose a patient phones me and he said, I'm in an acute attack. Can I guess how acute attack he has?
Speak. How well he speaks.
Okay.
Attack. I'm in an acute attack. Please come and talk to me. He said, that means he can go on talking for a long. But when you observe, what do you see? Suppose the diaphragm, what does diaphragm do during inspiration? Descend. If the diaphragm descends, what happens to the abdomen? Abdomen comes out. Okay, so during inspiration, the abdomen should rise, and during exhalation, this abdomen should fall. Now, if the person is taking breath and the damn abdomen is still scaphoid, that means the diaphragm is not going down. And in another case, suppose the diaphragm is moving up and down, but maybe the excursion is not there. That means intercostal. Which is more risky?
So basically, when the intercostal muscles are weak, will the thorax expand in inspiration or it will not expand? So in inspiration, it is the abdomen which is going up. So this is your seesaw movement which you see. So that is a sign of respiratory muscle paralysis or weakness, right? So you see that seesaw movement, upar niche, that is the sign of this, right?
And what is important is 80% of breathing is contributed to by diaphragm. That's the important. So if diaphragm is gone, be ready for intubation early. The intercostals are gone. When he's taking deep breath, the abdomen is rising because diaphragm is working, but intercostals are not working. So the chest is not rising simultaneously. That means diaphragm is working, intercostals are not. There is no urgency. But when diaphragm is going, prepare for any time for respiratory failure. And this can be diagnosed just by looking at the patient.
Of course, all that is when diaphragms are totally paralyzed, it's easy to make. But to begin with, just the voice and the rate of respiration. Okay, then can one side of diaphragm paralyzed would also give you the same problems? Or you need both the diaphragms going paralyzed? And can one diaphragm get paralyzed? Well, we said no, polio is patchy. Do you think one diaphragm is gone in GBS or something, or polio-like? Can one diaphragm be paralyzed? Phrenic nerve. If phrenic nerve is gone, and phrenic nerve sometimes is caught by some mediastinal lymph nodes, and you might have one diaphragm gone down. He may not be breathless because he has got one powerful diaphragm and rest of the intercostal muscles. But you might see the difference. Okay, and just keep a note on that, just because we are discussing diaphragm.
And eventation is another simile. The eventation on one side, the fellow goes on and on. Half diaphragm is working, half is not.
Okay. Any questions on this? Okay. Thank you.
Show me summary, slide 24. 24, summary, slide 24. Summary. Yeah, this one. Today I had a great lesson from Dr. Khare. Sir, thank you very much. He summarized in small 7 sentences which I understood. This summary has 75 words. Intelligent 150 IQ MD examine giving boy can tell, but the tired examiner may not take it all. You make your own choice. You can present 100 words, complicated sentence and pass without anybody hearing it, or you can make small sentences and make it happy. Number 2, you should have, see, common things are commonly correct and rare things are rarely correct. So for every sign and symptoms, you must know the commonest causes by heart, and they should come without asking. Like suppose a child has fever, it can be viral fever, it can be heat stroke, it can be malaria, it can be enteric. And for every sign and symptom, you make a list and make things by heart. You will pass without thinking.
Okay, Dr. Anjali, are you there? Have you logged into that link?
While she's getting ready, I remembered when we were presenting cases for MD exam going students, what sir had hammered into our head for paralysis is weakness, motor or sensory. Weakness, purely motor weakness, symmetrical, without bladder and bowel disturbances. That rules out or confirms 3 important causes. Purely motor is peripheral nerve, anterior horn cells, etc. Motor and sensory means sensory nerve is involved or the spinal cord. Pure motor and sensory, but bladder bowel is involved is transverse myelitis. Bladder bowel spared, that peripheral. So purely motor, motor plus sensory, symmetrical or not symmetrical. At our time, polio was not uncommon. With bladder and bowel, and then you have given the diagnosis, because these are 3 important DDs, na? Peripheral nerve, anterior horn cell, and a cord. So remember these 3 lines. Very good.
Good evening, Dr. Anjali. Can you hear us?
Hi. Yeah, can you hear me?
Yes, we can hear you. So
Okay.
you can start sharing your screen.
Yeah. Can you see my screen?
Yes. Sir.
Yeah, we can see.
Okay. Can I start?
Make it full screen.
Is it full screen now, Rajesh?
Yeah, it is.
Okay.
And if you want to kind of pause and ask some questions, I'll see if they'll answer. I'll hand over the mic to them. Yeah.
All right. Yeah.
Yeah.
Yeah. So I have 20 minutes.
Yes.
Okay. Yeah. Good evening, Dr. Ambekar, my dear friends, colleagues. It's such an honor to be here to share this with you. Today, I'm going to present IAP standard treatment guidelines and on anaphylaxis. This paper has been written by Dr. Neeraj Gupta, and it is the effort and under the auspices, I think it's a wonderful undertaking by IAP Action Plan, Dr. Ramesh Kumar and Dr. Upendra Kinjwadekar. And also it has been coordinated by Dr. Vineet Saxena. Anaphylaxis, the definition, first let me tell you why I chose to speak about anaphylaxis. While I was an undergraduate student, that was about 45 years ago, one of our colleagues, she was suffering from rheumatic fever and she had to take penicillin injection every 21 days. And after 2 years of taking this, while she was taking this injection in OPD, unfortunately, she died of anaphylaxis. 40 years later, that's about 6 months ago, an anesthetist colleague in Virar who had chickpea sensitivity, he was allergic to chole and he had gone for a seminar and he consumed that. He was uncomfortable However, he didn't do anything about it. And while he was in Sanjeevani Hospital giving anesthesia for a case, he collapsed. He was transferred to a hospital to Mumbai and he expired on the way. So something that we could treat, something that we could take care of. Over 40 years, we have not learned a lesson. And at least one of the following, that is a respiratory compromise or a circulatory compromise. By acute onset, we mean within minutes to hours. Involvement of the skin and mucosal tissue, we mean generalized hives or urticaria, pruritus, flushing, or an angioedema-like presentation. By respiratory compromise, we mean dyspnea, bronchospasm, or a stridor. Circulatory compromise, we mean a low blood pressure or associated symptoms of end organ dysfunction like syncope or incontinence. Very often in the OPD, we get a call from the RMO saying that, doctor, there is a patient who has come with all kinds of hives. He has eaten something and now he has rash all over and itching. Is this anaphylaxis? Now, how will one make out whether this is anaphylaxis? It's not just the presence of involvement of the skin, but it is also either one of respiratory. So we ask ourselves, does this child have respiratory compromise? Does he have a stridor? Does he have a wheeze? And does he have a circulatory compromise? The second criteria is two or more of the following that occur acutely after exposure to a likely allergen for that patient. I know so many people who are allergic to prawns, like our anesthetist friend, he was allergic to chickpea. So a likely allergen for that patient, if he has a respiratory compromise, circulatory compromise, or a persistent gastrointestinal symptom. So he may have no skin manifestation, but if he has any two or more of these, that is respiratory, circulatory, or a gastrointestinal symptom. So think of a patient who just before going home, we are going to give him an IV injection. We have given him whatever you give, any beta lactamase antibiotic, for example, and he suddenly develops nausea. He's all right before this, he's fine, he's going home. But after that injection, he develops nausea, vomiting, and severe abdominal pain, crampy abdomen. Think of anaphylaxis. Along with this, he may have some circulatory findings like a weak, thready pulse, or he may feel giddy or weak. So this is the second criteria. Whereas the third, acutely after exposure to known allergen for that patient, he has a reduced BP defined as low systemic blood pressure for age or more than 30% decrease in systolic blood pressure. So again, like for example, our anesthetic friend, if he knew that he was exposed to that allergen and he had taken care to measure his blood pressure and he found that it was low than what he used to record it earlier, then that should have warned him that he's going in for anaphylaxis. What is low systolic blood pressure? So low systolic blood pressure is defined as, there are so many criteria, less than 60 from birth to 1 month, less than 70 for those who are from 1 month to 1 year. And for those who are 1 year to 10 years, it's less than 70 plus 2 into age. And for all those above 11 years, and for all of us adults, it's less than 90 mm of mercury. What are the precipitating factors? Enteral ingestion, drugs like antibiotics, NSAIDs, aspirin, and food. They say that food-related allergy is the commonest cause of out-of-hospital anaphylaxis. It could be because of parenteral administration. So in-hospital causes of anaphylaxis is generally, and no lab parameters are required for diagnosis. So if a patient comes with any of the symptoms which we described, please don't go for lab parameters. It's only if you want to know if there is something more sinister like systemic mastocytosis or pseudoanaphylaxis, that we go for serum tryptase, but this is generally a very theoretical thing. There are many differential diagnoses. Like I said, that one of the things we very commonly see is an urticarial rash, and then we are worried, is this anaphylaxis? Another thing we commonly see is a vasovagal attack. I vaccinated the 10 years booster dose to a very good friend's daughter, and promptly after she got up from the vaccine, she fell down and she had a vasovagal attack. So how will you make out that this is anaphylaxis or has she collapsed because of a vasovagal attack? So generally, a vasovagal attack is very prompt. It's within seconds, whereas anaphylaxis will take, it takes a little while. One of my patients who was many years ago, now we don't see rheumatic fever so commonly. He also was taking penicillin. He took the penicillin, he took the test dose, he waited for a while, then we gave him the injection. Again, he waited for a while and he went home. So all this took about 45 minutes. He went home, it took 15 minutes. He came back in an hour saying that I'm feeling breathless. I'm getting a tightness in my throat. That was anaphylaxis. Whereas the previous patient, that girl who stood up and fell down, that was a vasovagal attack because it was within seconds, and the anaphylaxis took a little while. Common triggers, vasovagal attack is more common because of pain, fear, stress. Whereas anaphylaxis, there has been previous history of some kind of allergy with an insect bite or exercise or shellfish, which is very common. In anaphylaxis, the skin is red hot with wheals and itchy rashes, whereas vagal attack, you won't get that. The patient will be pale and cold. If you examine the respiratory system in anaphylaxis, you will get a wheeze or a stridor, whereas a vasovagal, you won't get that. You may have hypotension with tachycardia in anaphylaxis, bradycardia. GI system, like I said, since there is severe vasospasm in the abdomen, there'll be nausea and vomiting. In vasovagal, you won't have that. In anaphylaxis, there is no improvement for a substantial time unless you give IM adrenaline. Whereas a vasovagal attack, just giving a foot up position and waiting for a while treats the cause. Management algorithm. This is a drill, like we have a fire drill. I think we must know how to manage some of the very common and most feared. I think anaphylaxis is one thing which every doctor is afraid of and yet very ill prepared for. So how do we clinically suspect? So we had those three cases, one who comes with hives and any either respiratory or cardiac symptoms, one who has a known trigger and comes with two of either respiratory, abdominal or cardiac symptoms, or the third, anyone who has a change in his blood pressure after he has consumed or been exposed to any of the allergens that he is allergic to. So any of those three criteria, if the patient suspects, be aware. Initial management, that in the first minute when the patient comes, keep him supine unless he has respiratory distress. Assess ABC, heart rate, blood pressure, SpO2, give O2. If there is an insect bite, that's the only place or time that you will look for any allergen and try to remove it. But most often, the allergen cannot be removed. Try to remove if there has been a bee sting. Even a wasp sting, you won't find a sting in the body. And the first thing to do is administer the first dose of IM epinephrine or adrenaline. Traditionally, we look for hydrocortisone, Avil, Finargan, but none of these work and none of them have to be given. We have to give intramuscular adrenaline. It's given on the anterolateral aspect. One in 1,000 dilution.
Anjali, we lost you for a few words, so repeat your last two sentences.
Yeah. So give IM adrenaline. Am I heard now?
Yeah.
So give intramuscular adrenaline, 1 tuberculin unit per kg. So if it's a 15 kg, give 15 TU. If it's a 20 kg, that is if you know the weight. Otherwise, I'll tell you what is to be done. And give it on the anterolateral aspect of the thigh. It is to be given intramuscular. The common adrenaline ampule that we get is 1 in 1,000. So no further dilution is needed. And we are all very familiar with the tuberculin syringe. So with the tuberculin syringe or any 2 cc syringe that is available, you can aspirate and give. So the dose is 1 TU or 0.01 ml per kg of IM intramuscular adrenaline. And this can be repeated every 5 to 10 minutes as needed. So that is what we did when the child who I said was receiving penicillin, he came after an hour and said that I'm feeling breathless, I'm getting a catch in my throat. We gave him intramuscular adrenaline. Did he have distress? Yes. So we kept him in a sitting position. We gave him a little oxygen. However, his circulatory system was normal. He didn't have any hypotension or he didn't have any shocky symptoms. So what do we do in 1 to 5 minutes? If he has respiratory distress, we keep him in a sitting position, not supine. We give him high flow oxygen. You can use high flow nasal cannula. You keep yourself ready for intubation. If he has a stridor, you can give him adrenaline nebulization. If he has a wheeze, you can give him nebulized salbutamol. The dose is for nebulized adrenaline 0.5 ml per kg. Although it's given in this guideline now, I don't know how we can give adrenaline 0.5 for a 10 kg baby, 5 cc's. That would be a little difficult, but the idea being that give adrenaline as nebulization. And if there is a wheeze, give salbutamol in the dose of 0.15 mg per kg. If he has hypotension, keep him supine, start an IV and give him a bolus of IV fluids. This is the first 5 minutes. In the next 5 to 10 minutes, if there is an improvement, keep this patient under observation. If he has not improved, give him a second dose of adrenaline. The dose is the same, 0.01 ml, that is 1 tuberculin unit per kg. Start an IV. If there is again respiratory distress which is persistent, you can continue nebulizing him for a stridor with adrenaline, and if he has a wheeze, with salbutamol. If he has hypotension still persistent after the first bolus, give him a second bolus. After 10 minutes, if there has been an improvement, excellent. Just keep him under observation. If not, you can give him a third dose of epinephrine or adrenaline. And the same thing as before, if there is a stridor, give him adrenaline. If there is a wheeze, give him nebulized salbutamol. And within 10 minutes, proceed for intubation and be ready for a very difficult intubation because you may have laryngeal edema. If there is hypotension or poor perfusion, now you can start IV adrenaline in the dose of 0.05 micrograms per kg per minute. It's always a very good idea to keep the dilution and the dose ready per kg in your emergency room so that you don't have to make all calculations. We have a chart where we keep per kg in tuberculin units ready, and all we have to do is just dilute that epinephrine to that dilution and give it accordingly. And if within 10 to 20 minutes we feel this patient is still in shock, still in hypotension, then we have to transfer this patient to a pediatric ICU, and thereafter it will be followed as per ICU protocols. So in all this, I hope that we have realized that there is no place for hydrocortisone, no place for ARIL. All we have to do is IM adrenaline and keep that ready. Monitoring and follow-up, delayed INF, we may have a biphasic reaction that usually comes after 4 hours and up to 36 hours. So keep this patient under close observation, at least for 4 hours if you have administered intramuscular adrenaline. And if he's fine and he goes home, then please see that you call him every day to see him. And keep monitoring his blood pressure and SpO2 and of course respiratory symptoms. Follow-up of the patient should be done for at least 4 hours after the last dose, and in severe hospitalized cases for minimum 3 days. And why would you hospitalize a patient who has anaphylaxis? If he has a persistent tachycardia or hypotension, if his stridor or wheeze has not improved after your 2 or 3 doses, if his SpO2 is not maintained, if he has a previous history of anaphylaxis, or if he has any comorbidities like asthma or a heart disease, or if he lives in a remote area, or he has come late in the evening. What is important is to have a home action plan. Our son is allergic to pollen, and once when he went to play with his friends, he played football and he lied down on the grass, and immediately within minutes he was covered with hives, and he came home and he had angioedema, and I was very afraid that he would go into anaphylaxis. Fortunately, it didn't happen. But now I have given him adrenaline injection to keep with him, because this can happen again and it could be too late. So we don't have EpiPen. Abroad, they have something called EpiPen, or an injectable penicillin, which is injectable adrenaline, which is available for all children and adults. If the patient is from 8 to 25 kgs, they have to be given the 0.15 mg of EpiPen. It has to be taught to the mother how it is given. If the patient is between 25 to 40 kgs, we give 0.3 mg. It's a ready syringe which is available. And if it's an adult, it's a 0.5 mg. That's a half a cc of adrenaline which has to be injected. Adults should know how to inject themselves on the lateral thigh. So we have to teach everyone how it has to be given. We have to teach the mother to look for signs. And it can be kept at, so this adrenaline is really so cheap, it just costs a rupee or two. And it has a very short expiry. That's one of the problems with adrenaline. It changes its color, and also it has a very short expiry of 3 to 6 months. But we must keep it with us because we don't have EpiPen. And of course, we must know where emergency numbers should be kept handy. So if our anesthetist friend had noticed that he had this allergy, and he had noted his blood pressure and he found it low, the first thing he should have done was to take an intramuscular adrenaline even before he went to any hospital. So we have to learn to teach our parents, and we have to learn to take it ourselves too. This is what I have done for my son, and this is what I would want each one of us who've ever experienced any kind of severe allergic reaction to do. Adrenaline, there's a very small, this box is very small, it fits into the palm and can be kept in the pocket. Adrenaline, write the expiry, write the adult dose, 0.5 ml, and it has to be given. It should be available handy in everyone's bag, in everyone's OPD. It costs nothing. This is how on the inside, if you give it to someone, if you give it to the mother, then you can write the weight and say if the child weighs this much, this is how much it has to be given. This ampule, earlier we needed an injection cutter to cut it, but now it's available as a, you can just click it open. And in our emergency room, we have management as the cornerstone in good outcome. IM epinephrine is the only drug to be given. It's the drug of choice. Follow-up of the patient for minimum 3 days, because it could be a biphasic reaction we see. And education of parents about its early recognition and appropriate management is the need of the hour. That's all. Thank you so much.
Any questions?
I'll make few comments. I have seen 6 anaphylaxis managed by MD, MS postgraduates. nobody gave adrenaline. So lesson number one, it has to become a reflex. So you have to have a drill. It is not a one-man job. Suppose you are in shock. So you say adrenaline, then the two nurses who are available, both of them run for adrenaline. Then you want saline. So that should not happen. You have to rehearse this. When you say adrenaline, someone says, I bring adrenaline, and she goes and gets adrenaline. Someone says, I get saline, and she gets saline. And this has to happen spontaneously. So you have to train them. So abroad, once a month, there is a fire in every place. So we need to have a anaphylaxis drill in our own place. Then now India makes pre-filled syringes of vaccines. We all should ask them to have pre-filled syringes of adrenaline. They can easily make it for us. And that's it. Thank you.
Anjali, I had a question. It struck me as you were speaking. So we get these patients with urticaria. So what is the time frame of progression? So is it always just a minute, or it can drag on? Somebody comes to me after 20 minutes of urticaria and I find no respiratory compromise. And I send them back, and can they come back with compromise in some time?
Yes, it is known that it can occur even up to like 4 hours later. So the time frame would be 4 hours. But Rajesh, what we normally do if there is severe urticaria, we give adrenaline anyway, because even urticaria is known to respond to adrenaline. So because it is IgE mediated. And if it does not progress to anaphylaxis, at the most that IM adrenaline will cause a little tachycardia. So severe anaphylaxis, severe urticaria, we do give adrenaline.
I want all of us to remember ABC of anaphylaxis. A is adrenaline. B is we need blood pressure later on, or breathing difficulties, that is oxygen suction. And C is saline. 2 whiteboard needles and 2 salines for rapid bolus. That's it.
Any other questions?
When I was intern, I was worried that somebody had a problem, and I gave adrenaline. I was the only person in the whole district hospital. So I gave him adrenaline. And then a whole night I was worried whether he will die of tachycardia. So I sat with the adult patient. Nothing happened. Adrenaline is safe. Don't worry. Use it. When in doubt, you give it. Nothing happens.
We have to remember the dose. I think since we use a tuberculin syringe and we are very familiar with TU units, the dose is 1 TU per kg of 1 in 1000 adrenaline.
Yeah, so only thing is, like you said, if you use a regular syringe, then it can be a bit dicey, because it would be 0.1 ml for 10 kg.
Yes.
So in your regular 2 cc syringe, it would be just 0.1 ml for 10 kg. And it's very difficult to measure that 0.1 ml or 0.2. And 0.3 is the max dose in a child, and in an adult 0.5. So that's one. And you were mentioning, Anjali, the inhaled adrenaline dose. So actually that is right. The inhaled adrenaline dose is 0.5 mg per kg, ml per kg. So which means in a 10 kg child, you need 5 ampoules of adrenaline to nebulize this child. So when you are doing nebulization of adrenaline for a child with croup, remember that you have to put 5 ampoules for a 10 kg child. Don't wonder, no, I must have got the dose wrong. You have to put 5 ampoules.
Okay, great point.
That's 5 ampoules. Maximum is 5.
And adrenaline will be better than salbutamol in the case of anaphylaxis for inhalation.
2 small things. One is our solution is 1 in 1000, and we have to give the dose often easily remembered and easily administered in the absence of tuberculin syringes in 1 in 10,000. So I was told, and I had it in mind, is in a normal syringe, which is very easily available, we often may not have tuberculosis syringe, take 0.1 ml of the adrenaline 1 in 10,000 solution, 1 in 1,000 solution, dilute it to 1 ml. So it is 1 in 10,000, and then you give it because it is easily administered and it is readily possible because of the syringe which and secondly, even if the IV is going on, the patient is on IV for some reason and he develops anaphylaxis, don't give an IV adrenaline. You may be tempted to give IV. IV hai, chalo, better. If IM is better, IV is better. It is not.
So this is a very important point that sir has mentioned, that the route is IM only, right? So that is important. And Palni has given a tip that if a patient developing hives, if lower lip or tongue is involved, he is on the verge of developing laryngeal edema and choking. So that's, he's suggesting that, so we'll remember that. So
yeah, and now adrenaline has 1 year expiry.
Now this, what Khare sir said about 1 in 10,000, and also that's all very confusing. So I would suggest that please stick to one dose and one dilution and stick to that. Don't keep jumping between 10,000 and 1,000 and then jumbling up your doses and going haywire, right?
So all of us have to keep a 2 cc syringe, a tuberculin syringe, and one adrenaline ampoule by our side in our OPD, because we all give vaccines, we all give injections, and we may get a patient of anaphylaxis at any time. We have to be prepared. It's a fire drill, just like we have fire extinguishers in our hospitals and homes. I think we should have adrenaline with us at all times, so that we suspect and give, because most of the times when patients die of anaphylaxis, it's because of a delayed diagnosis and delayed management. So it's because of a lapse in our therapeutics.
I think, Anjali, what you said about the urticaria going even hours later into a complication is really an immunodeficiency patient and a subclass IgG1. Normally, we don't do that. So that's why it is rare. But yes, we may have to do that. But I'm sure my colleagues remember that we had an 8-month-old child and exclusively breastfed, complementary feeds. And for some reason, she gave a formula feed. And not only feed, just the first touch, and the whole lips got swollen and the child started behaving badly. They rushed to our clinic and we knew that this child was tremendously going into anaphylaxis out of just the animal protein. That child is now about 20-year-old. And now also he doesn't take, he knows that any milk product he should not take. So that is the only one time that we have seen such a thing to happen. You all remember that child. And once after 5 years, we wanted to test whether he has outgrown it or not. And we all were present, adrenaline filled. And moment that a spoon was touched, he started getting swelling. Okay, thereafter he has never taken anything. He's doing well otherwise. Yeah.
Yes, they say that even when doing an allergy test for milk protein allergy, one has to be prepared for anaphylaxis, and it has to be done in a hospital setting, because it's known. And therefore, vaccines also have to be given in hospital settings and not at home or, as per the patient requires.
Yeah, so 2 lessons today. 1, follow Hippocratic Oath. Be judicious, no unnecessary medicines or vaccines or injections. Number 1. Number 2, to teach this drill, we actually did a drama for all doctors and nurses in our place. One patient came to a doctor who gives injections to everybody. He gave it, and then he had anaphylaxis. And then he went to search for his oxygen. It was not working. His phone, it was not working. He could not get saline. He could get nothing. Then he shouted. So his friends came, and those who were used to it, then they saved that patient. Like one said A, then he said adrenaline, then said B. So B went off breathing. they arranged for breathing and suction oxygen. And then he said, see, so somebody arranged saline, 2 salines, and then they saved him. It was a drama, but that trained all my staff for any emergencies. You all should do it before you sleep tonight.
Thank you.
Thank you.
I recall one of the lectures on anaphylaxis. Somebody got up from the audience and said, I have faced myself. Before that, you must know that you support yourself near the wall while cutting an ampule of adrenaline, you may faint. Because really seeing that emergency, the bottom line is we should have adrenaline filled every day in the morning. It's a cheap drug.
Yes.
And you can throw that 24 hourly.
Yeah.
And I remember at JJ in my ward, I had made a routine. Every morning a fresh adrenaline syringe is filled and you throw that out next day. It's so cheap, but it can just save life. Because he said that, sir, while cutting the ampule, your hand shakes, you cannot cut the ampule and you may faint. So I realized that treating anaphylaxis, what he said, it's not one person's job. And if you are alone, it's better you have an adrenaline filled every day.
Yeah, sir, one difference is that earlier we used to get that ampule which needed a cutter, but now we get an adrenaline which can be flipped open. So it's easier to, fill it even instantly.
Can I keep it for 1 or 2 days, or every day I have to prepare? If I keep it in the syringe loaded, but I don't open or anything, keep it like that, then stability is.
Then they say that it can be kept for some
Abroad
time.
now there is an availability as a shelf life. I don't recall how long, but a shelf life. And those who are allergic even carry with them. Okay, so that is possible.
No, it should not be given subcutaneously. The reason is that when you are in anaphylaxis, you are in shock. So your circulation is compromised and your subcut will not absorb it enough to reach it where it is needed. So therefore, it should not be given subcut.
So actually this dabba is of the type bar TCV, and it's got a very nice place where you can, keep the adrenaline. So this way that adrenaline stays there and a 2 cc syringe fits very comfortably. It's very good to give adult patients because adult patients, can carry this in their purse, pocket or their backpack. So I've given it to our son and I've told him to keep it in his office, at home and in his backpack so that anytime it's needed, he can take. And he has to take it before he goes to any hospital.
So if you don't want to be sad, have adrenaline with you. Add adrenaline to your bag.
Okay. Thank you. Thank you so much, Dr.
Thank you.
Anjali. And
Thank you.
thank you all our online viewers. Thank you, Dr. Palni, for your useful tips. And we meet once again next Thursday evening, 6 p.m. for the same clinic again. Thank you.
Thank you so much.